I'm really excited for this discussion today with Max Frazier. Max is a professor of history at the University of Miami, where his research and teaching focuses on working class life and the social movements in the 20th century US, as well as the rise of new strains of conservatism in the decades after the Second World War. He's completing a book titled Hillbilly Highway, Trans-Appalachia and the Making of a White Working Class, which is scheduled to be published by Princeton University Press and promises to be an indispensable resource for understanding the politics of our times. Max is also a longtime contributor to New Labor Forum with his Organized Money column, which helps us get in the minds of corporate America. I always say we should all be reading the Financial Times and Wall Street Journal more frequently, but for those who just can't stand to do that, which I can commiserate with, you can count on Max to bring you some of the latest developments in a very succinct and incisive way. Our discussion today is inspired by Max's most recent Organized Money column, in which he explores the impact private equity firms have had on the healthcare industry, and in particular, the role they've played in limiting access to care in rural areas through hospital closures and service reductions. Unfortunately, as we all know, the pandemic is now raging in rural America, with cases per capita in such places climbing much more rapidly than in large metro areas. With limited hospital capacity even before the pandemic, these areas are now under significant pressure, and that's unfortunately only going to intensify in the months to come. Max shows in his article that this limited hospital capacity didn't come out of nowhere. According to the Sheps Center for Rural Health Services Research at the University of North Carolina, Chapel Hill, there have been 134 rural hospital closures over the past decade. That amounts to a little more than one per month. A disproportionate share of these closures have occurred at for-profit hospitals, with private equity and other predatory investors playing a significant role. Private equity has also been invested in long-term care facilities, with one recent study showing that nursing homes owned by private equity spend more and have a higher mortality rate than comparable institutions. They're also deeply wound up with medical billing companies, physician staffing firms, and even ambulance operators. In fact, healthcare has been one of the fastest growing sectors of private equity investment in recent years, and all signs point to that continuing. One recent survey of private equity executives found that they consider healthcare to be the most attractive investment industry going forward. So given all these trends and the public health nightmare we're living through, Max's article in this discussion couldn't be more timely. And with that, Max, thank you so much for being here. And to get us going, perhaps you could take a step back and explain what this somewhat perhaps unfamiliar term private equity means and how it works.
Yeah, sure. Well, and thanks for having me. It's complicated, of course, but to radically simplify, private equity firms are financial companies which raise investment capital from a variety of sources, typically, institutional investors like pension funds, insurance companies, university endowments, sovereign wealth funds, those kind of entities, also so-called high wealth individuals, rich people. And pool that investment capital into funds that they use to acquire equity ownership stakes of companies, typically privately traded companies. The goal for private equity is to use those investments, make those investments over a relatively short time window, typically 3 to 5 years. And in that time, restructure the companies that they buy in a whole variety of different kinds of ways to enhance their profitability, with the goal again of exiting the investment in that sort of ideal time window at a profit. Whether that means selling the company to another private buyer or bringing it to a public offering. So that's the sort of typical private equity approach. The business model that they typically deploy in financing those acquisitions are the sort of so-called leveraged buyouts. So these are typically acquisitions that involve a great deal of debt. A small portion of the overall acquisition is financed by the equity investment of the firm and its gathered investors, and a larger share of it is debt that is taken on by the company being purchased. Right, in other words, its assets become the collateral for that debt. So Using debt to finance the investments allows private equity firms and their investors to, multiply their investment in the long run when they're exiting it at the end, and at the same time, it often creates highly leveraged or indebted companies that sort of have been acquired by those investors.
And the story about debt is really central. And if people pay attention to the bankruptcies that you read about in the financial press, often you can trace it back to a private equity company. Most recently, and perhaps infamously, Toys R Us, which went bankrupt. And we've heard about this in retail and in other industries a lot. But I'm curious why investors like this are so attracted to healthcare, and I guess also in particular, sort of related to your article, why rural healthcare, because maybe I'm missing something, but it doesn't seem like that would be the most profitable investment to begin with. So why are these types of investors drawn to the healthcare industry in general, and rural health facilities in particular?
Yeah, well, and you're right to note the peculiarity of rural healthcare providers, rural hospitals being unusual, given that we think of them, even if we don't think of them very often, as being sort of financially distressed or not necessarily the most valuable assets. In a funny way, the answer to your first question, why healthcare, and your second question, why rural hospitals in particular, or rural healthcare providers are similar. The most straightforward answer about why healthcare, of course, is that it's one of the most rapidly growing sectors of the overall economy, right? I mean, healthcare spending today accounts for nearly 20% of GDP, of course, growing at equivalent rates globally. So it is as a broader sector of the economy, it's one of the most, leading profit-generating sectors of the economy overall. It also tends to be what investors would call a kind of fragmented market. A lot of individual, local, regional, small providers of various kinds, whether that's hospitals or other kinds of healthcare providers, outpatient clinics. You mentioned some of the other healthcare entities that private equity has invested in, ambulance companies, emergency room service providers, billing, revenue management companies. So there's a lot of small companies that make up the broader healthcare market, obviously, and that's ideal for something that private equity likes to do in any case when it buys companies, which is often make an initial investment and then build it out, right? To build national sort of economies of scale in the market, in the segments that it invests in, which can allow it to, exert market power to undermine competition, reduce costs, increase prices, do a variety of things. And so the healthcare market is particularly open to that kind of buying to build, you might say. Another thing to keep in mind about healthcare is that of that massive pot of healthcare spending, right, that accounts for such a large share of GDP, a very significant portion of that is effectively sort of guaranteed income streams, right, which come from the federal government and other sort of so-called third-party payers, right? Today, through Medicare, Medicaid, and other government programs, the federal government is responsible for 40% of that giant, larger pool of healthcare spending. So that means that there's a certain reliable cash flow in these businesses, in the healthcare sector broadly, that a sort of equivalent entity like Toys R Us in retail, there doesn't exist, right? If the economy tanks, people stop buying toys, and that sort of guaranteed revenue stream or cash flow goes away. So healthcare has that advantage also. The question about rural, I don't want to lose sight of, though, because I think rural hospitals, rural healthcare providers are certainly not the most profitable sectors of the healthcare market, and haven't been for some time. But on the other hand, what that makes them is, as distressed assets, right? Relatively cheap assets to acquire, and to acquire particularly in this in what private equity often tries to do, acquiring a lot of small companies and smashing them together into larger regional or even national chains, or sort of national healthcare systems of one kind or another. And it's relatively easy to do that in rural markets, on the one hand, because the assets themselves are cheap. And on the other hand, because they're cheap enough, or furthermore, because they're cheap enough and in scattered enough markets that they often sort of fly below the radar of federal regulatory oversight around questions of antitrust and things like that. So these are often easy acquisitions to make, both financially and from an oversight perspective. I think that's why private equity has been able to make a quick, has been able to make a quick sort of entry into that market. And of course, it sees an opportunity to, with any asset you can buy cheaply, to, if it can build it up into a profitable entity, to again, exit that investment, right? Flip that acquisition to a profit, which is, its long-term goal. Private equity, we should remember, these are investors who are not making investments. They're not buying to own and operate a property in the long term, but to sell it, right? And so the goal here would be to sell those companies, those healthcare providers, quickly.
Right. So the buy low, sell high model is part of it, and your point about the guaranteed revenue streams from public and other sources makes a lot of sense, and presumably in a time of a health crisis makes even more sense, which I guess could explain why these industry executives who were recently surveyed by some scholars said that this is one of the most attractive industries going forward. I guess that's what they're saying, but surveying the landscape the way that you have, do you think all of this adds up? Do the numbers make sense?
Well, it's yes and no. On the one hand, there's the sort of classic example of the sort of gold standard over the last 20 years, when private equity investment in the healthcare market has really increased, is the 2006 acquisition of the Hospital Corporation of America, the largest hospital chain in the country, by a consortium of private equity firms led by Bain Capital. Bain, KKR, a handful of other very prominent private equity firms financed that acquisition. In 2006, brought Hospital Corporation of America private, brought it public again 5 years later. And in that time, Bain's initial investment of, I think it was a little more than $500 million, I'm sorry, much less than that, maybe 75 million, turned into $1.5 billion at the end of that. So this was the sort of gold standard, and has driven a lot of private equity activity in the broader market over the last period of time, attempting to replicate that.
Sure.
And more often than not, those kinds of profits have not been there, I don't think. But what's worth remembering is that private equity firms have a variety of ways of making money off of their acquisitions prior to that moment where they exit the investment, right? Where they sell it, hopefully for a huge profit, the way Bain and KKR and others were able to do with Hospital Corporation of America. So one example of this, Apollo Global Management, which is another leading private equity firm, has been buying up hospital networks a lot over the last 5 years. Its last major acquisition in 2018, it bought the system LifePoint Health, combined it with a few other systems that it had purchased, and now operates LifePoint Health as a network of 84 largely rural hospitals across 30 states. It spent $5.5 billion on the sort of linchpin of that investment in 2018. In 2019, it took 10 of the hospitals it had purchased as part of the LifePoint Health system and sold it to a real estate investment trust for $700 million as part of a sale leaseback operation. So it took assets that LifePoint Health owned at the time that it acquired the company, sold them to another for a bunch of money, for $700 million, and then is leasing that same property. So continuing to operate the hospital, but has effectively stripped the asset that the company had previously owned. So asset stripping, right? And that's one example of it, is one way that private equity can make money out of its investments prior to, bringing it public, or without making the company itself any more profitable. Notably, LifePoint Health and a handful of other hospital companies, healthcare companies owned by private equity firms, have been major recipients in 2020 of COVID relief funds.
Right.
LifePoint Health received $1.5 billion in COVID relief aid, even though it is a privately owned company whose primary owner, Apollo Global Management, is something like, I don't know, I think it's that latest count, 300, maybe more than that, $1 billion in assets under management. So another way in which, Apollo has been able to reap benefits out of its investment, even without restoring the profitability of the country. In this case, benefiting off of it, the economic hardship that all healthcare companies have been facing, during the pandemic. So, I think the question is not, are these investments profitable in the long run? Sometimes they are, sometimes they aren't. But the point is, they often put the private equity firm and the investors behind those investments in a position to earn back their equity investment in a variety of different kinds of ways, through this sort of predatory investment model.
Right, right. So, I mean, this sort of financial engineering that you're describing, of which let's say the sale leaseback is one feature, can help to generate dazzling returns in the short term, which presumably explains why investors like pension funds and university endowments are so attracted to them. But on the other hand,
if I can just,
yeah, please.
Right? I mean, I think you're the dazzling returns for the private equity firm and its investors, right? And for the institutional investors' investment in the private equity fund, not necessarily returns for the purchased company, right? The portfolio company itself. Yeah, that's exactly right. In other words, when Apollo made this sale of LifePoint Health hospitals for that $700 million, there was no obligation on Apollo's part to put that money into paying down LifePoint Health's debt, or in other ways, improving the financial position of the company. That money was paid out to its investors, and owners. Yeah, go ahead.
Right. No, and that's a really important point, because, we often, and again, an example, the industry that seems to me to have received the most attention on this is retail, where there have been a flurry of bankruptcies in recent years, which the popular press easily attributes to, e-commerce and Amazon and all the rest of it, which surely is playing some role. But when you dig a little bit beneath the surface, you often see similar dynamics to what you're describing, and it's spectacular returns for the investment firm and their limited partners, which are their investors. But a shell of a company left behind in many cases that's vulnerable to bankruptcy, and there's a real dissonance there between the bankrupt company that they owned and the incredible returns that they've made. And of course, workers and retirees are left holding the bag, as well as creditors and other stakeholders involved. And so, I guess maybe that's a nice segue into we've been talking a bit in the abstract about how these companies work, and then also how they generate returns for themselves. But moving to some of the other stakeholders, let's say, to use a buzzword in this world, you talk in the article about a specific case at Community Health Systems, which was like HCA, one of the large publicly traded hospital corporations, as well as its spinoff Quorum Health Corporation. This, as you note in the piece, was one of the first instances of private equity investment in a hospital company, at least in the mid 90s. So can you? And there were some problems, to say the least, associated with that. So could you talk a little bit about the CHS and the Quorum case and what it reveals about this business model in healthcare?
Yeah, I mean, it's a perfect example of what we've just been talking about. I mean, the investment, right, which really was the first major private equity investment in the hospital market, was a ringing success for the private equity firm that financed it. Forsman Little brought community health systems private in 1996. By the time Forsman Little fully exited its investment in, I think, 2004 or so, its initial investment had tripled in value. It had tripled the value of its initial investment. In the process, though, it created a profoundly economically unhealthy company. When Community Health Systems had its initial public offering, again, was after its sort of restructuring in 2001, I believe. It entered became a publicly traded company, again, with a debt to equity ratio of, I think, about 160%, which is, probably meaningless to most of us, but for some comparison, that's about 4 times what a typical publicly traded company has in terms of the ratio of its debt to equity on its balance sheets. So that was in 2001. Between then and, or I think 2000, between then and about 2017, Community Health Systems, with a lot of private equity funding, even though private equity was no longer the owner, no longer owned the largest share of the company, engage on a kind of blitzkrieg of mergers and acquisitions, buying up something like 65 other hospital systems around the country, kind of replicating the buy and build, leverage buyout private equity model. By 2017, CHS had become the largest hospital system in the country by number of hospitals. So HCA was the largest by revenue, but CHS was the largest by number of hospitals. But at that point, its debt to equity ratio had ballooned to something like 400%. Wow. So it was 3 times as high as it was when it went public. So by no means was this a economically viable company. And so in 2017, in part as it was no longer able to meet its debt obligations, CHS began divesting itself of hospitals rapidly, right? Trying to sell off all of the over-leveraged property it had accumulated. It took a group of least valuable properties, rural hospitals, 38 of them, and it spun them off into a separate entity called Quorum Health. Quorum Health had been a sort of subsidiary of CHS for a while. It spun it off as a separate entity. CHS made $1.2 billion off of spinning off this sort of separate rural hospital network it called Quorum. Quorum paid it $1.2 billion, and in the same time assumed $1 billion of CHS's worst junk kind of speculative grade debt. So Quorum was created out of the ruins, right, of the CHS private equity mega hospital chain that was created. Almost with, the least valuable properties, these rural hospitals, right? CHS decided it was going to move into more profitable sectors, reduce its holdings, and eliminate its rural investments. Quorum Health was left with those least valuable investments and $1 billion in really terrible debt, and almost immediately began losing money and then selling properties itself, right? And so, as I call it in my column, rather than a sort of rural hospital operator, it really became a kind of rural hospital chop shop, just selling off these assets for whatever bargain basement prices it could acquire. By the end of 2019, of the original 38 properties that had been sort of put into this shell company of Quorum, 14 had been divested, 4 of them had been shut down entirely, and many others continue to be financially struggling. And then in April of this year, Quorum itself declared bankruptcy, sort of inevitable outcome given the financial position the company had been put in at its creation. So again, the initial sort of creation of Community Health System reaped huge profits for the private equity firm that drove its expansion and the creation of its national system, but it did nothing to ameliorate the very sort of vulnerable financial position, and in fact worsened the vulnerable financial system of the particularly the rural hospitals that were part of that acquisition. The hospitals that have closed down, we're talking, like you say, jobs, we're talking about retirees, particularly in the case of rural hospitals, we're talking about often the sole acute healthcare providers for large stretches of the local area, right? So these were often the only hospitals that provided acute care for, in that county for 30 miles in any direction, whatever it might be. And so the consequences for the communities in terms of their access to healthcare has been really extraordinarily detrimental. And sort of that was all sort of leading up to the disaster, the public health disaster and economic disaster, right, of the pandemic, right, which sort of has landed like a bomb on the rural healthcare market, one that's already been so hobbled and weakened by this sort of predatory investment over the last couple of decades.
Yeah, this is all, I have to say, extremely chilling to hear, because I live in Philadelphia, a very different kind of place from what you're describing. But just last year, Hahnemann University Hospital, which is a historic safety net institution that had been around for well over a century, was closed by a similar predatory investor who apparently bought the hospital about a year and a half earlier with the intention of shuttering it and flipping the real estate. And I should say, in full disclosure, I was working for the nurses union that represented the RNs at the hospital, and so I was deeply involved in this, and was involved in what became a really large labor and community mobilization to fight the closure that went on for weeks, and ultimately it was unsuccessful in a way that reveals a lot about fiscal priorities at the state and city level. But it did result in an ongoing dialogue among unionists, community activists, and certain elected officials around what happened, around the need to regulate for-profit investment in the city's healthcare sector, and really the need for a public hospital in the city that can serve the patient population that Hahnemann did. And I guess I'm wondering, I'm sure in different parts of the country, in these rural areas, there was community opposition to these closures, and I'm not familiar with it, and I certainly don't want to slight it, but it does seem like there hasn't been a groundswell or an uproar of the scale that you might imagine, given that, again, on average, about one rural hospital has been closing a month for a decade now. So I'm wondering, just looking at the politics around this, if you can talk a little bit about why that might be.
Yeah, well, I think it's a good question, and the answer is probably sort of determined by or connected to much sort of bigger political questions about a certain kind of political landscape in rural America today. I mean, I think the Hahnemann case that you're talking about was a sort of kind of particularly egregious example where the private equity firm Paladin really did seem to buy this property kind of right in the center of sort of right in the middle of sort of downtown Philadelphia, with the intention of it being really a real estate investment, right? Of allowing the very quickly allowing the hospital to just go out of business so that it could own this more valuable real estate in the middle of a gentrifying city. And that played out on a relatively short timeline from the time of the initial purchase. Under normal circumstances, though, right, it's part of, say, like what I was just describing about the case of these hospitals that passed through private equity ownership at Community Health, or ended up as part of the Quorum network. It is the long-term effects of private equity ownership and the way that they weaken the economic and the financial stability of rural healthcare providers it doesn't happen right away. It sort of takes a while to see that unfold, even unless you're studying the annual reports and doing the kind of financial probing, looking at the debt to equity ratios and these kinds of things. But it's not quite as obvious as in the case of Hanneman, where, within a year or two, that property was up for sale. And it just seemed like a real estate flip more than anything else. So I think that's one challenge. I think the fact that these are, as we said earlier, distressed assets, right? These are rural hospitals in deeply distressed communities, often. And it's worth keeping in mind that private equity investment in hospitals, private equity is more likely to be invested in rural hospitals than non-private equity owned hospitals, is more likely to be in lower income communities. So private equity really targets, in a large part, rural, poorer communities, in part because those communities, to keep their hospitals open, are desperate for private investment. And in a moment like the one we are living in, hopefully, prior to the passage of Medicare for all and a wholesale transformation of healthcare delivery in this country, there are not many places that financially distressed rural hospitals can turn for financial lifelines other than private investors, right? And they may even have, even knowing the potential for that investment to be a predatory one, right? Or one that isn't necessarily, it might at a certain moment be the only thing that can keep the doors open, right? In the way that, as you said at the outset, right? We've seen something like 175 rural hospital closures since 2005. Again, most of those, the majority have been in, have been hospitals that are either critical access hospitals, right, which means that they're the sole provider of acute care in a sort of 35-mile radius, or Medicare dependent hospitals, which means that at least 60% of their patients are on Medicare. So these are the kinds of hospitals that have been closing are these most distressed communities as well. So I think, so there's the sort of investment horizon question and the sort of challenge of determining whether or not those investments are predatory in the moment, right? There's the desperation of the communities themselves, which often only see for whom private equity is often the only way to keep those hospitals open. And then, of course, Philadelphia is a different place than, Salina, Tennessee, right? Or Bluefield, West Virginia, these places which have seen rural hospitals close down over the last 8 months, right? During the pandemic, in the sense that there is a robust labor and community movement there, right? There is a kind of infrastructure of organizing and that is able to maybe push back or build the kind of coalition that existed in Philadelphia. And you don't see as much of that in rural America today as you do in certain kind of, again, not every American city by a long shot, but in more progressive and better organized cities like Philadelphia. So I think that's maybe a challenge about why you've seen less of a pushback. Again, not none, but not the same kind of broad-based ongoing campaigns like in the Hanneman case in Philly.
Right. And on that note, and maybe moving in that direction, we've of course just had another election to remind us of just that incredibly stark rural metropolitan political divide. And it's been for some time one of the great questions of US politics that scholars like yourself, political strategists, organizers, and many others have tried to make sense of. And you've been working on this for some time, and have written elsewhere that I'm gonna quote here: any explanation of this divide that we're all puzzling over, that we've all been puzzling over for some time, must emphasize the real conditions under which rural America has been systematically marginalized, exploited, and distanced from national centers of economic and social power both historically and with increasing severity in recent years. So starting with the historical, and then perhaps moving up in time, can you talk a bit about how this thing that we call rural America was cut off from the national centers of economic and social power, and why that's important?
Yeah, I mean, it's a big question, but I think, since at least the populist uprising of the late 19th century, if not before then, right, we've seen the kinds of ways in which um, capital that is sort of originates outside of rural America has been used to, extract various kinds of natural resources, from coal and lumber to crops of various kinds, right? And has created a sort of fundamentally unequal relationship between the centers of economic and political power in the country and the sort of rural hinterland, right? Or the rural kind of the rural hinterland in the sense of kind of economic idea about that term. So, I mean, that's a very abbreviated kind of sense of the historical, maybe not origins, but continuity here, right? And I think the thing that the growth of that the 20th century sort of economic history and economic development did not alter, right, was this fundamental dynamic, right? Even in the moment of kind of economic planning envisioned by the New Deal, right, which embraced a variety of developmentalist programs aiming to sort of increase the economic sort of self-reliance of rural America in different ways. Failed largely to disturb the sort of, or had no intention of altering the broader sort of arrangements of capital and property relations or centers of capital control and investment in the country, right? And so rural America remained throughout the sort of New Deal and post-New Deal period kind of dependent on outside capital, larger national markets, a sort of junior partner in large parts to centers of economic activity, whether that was industrial activity or financial activity concentrated elsewhere. I think, the current problem, let's say, or the current way in which this remains, is, I would say, the failure of, the Democratic Party, let's say, as a kind of stand-in, inadequate though it may be for the left in America, to articulate a kind of economic agenda for rural America that is able to undo that sort of historically entrenched, economic disadvantage and marginalization that still confronts rural America and is one of the causes of, why these communities that we've been talking about, where that rural hospitals serve, are so economically distressed to begin with, right? Why rural America is by and large poorer than urban America, why it's more underinsured than urban America, why it has worse health outcomes and health disparities to begin with than urban America, right? And the economic causes for that are clear. The economic solutions to that have been few and far between, right? Even in the kind of platform of the Democratic Party, and so it makes rural America in a variety of ways a sort of, on the one hand, landscape that's ripe for predatory investment, right? And on the other hand, as we see politically, prone to all kinds of sort of reactionary politics, right? And a real problem, I would say, for progressive organizers and progressive movement builders who see rural America rightly, I would say, at least in an electoral sense right now, as an obstacle, right, to that, right, as a source of the conservative opposition. And I think that is a legacy of, in addition to the sort of field day that private equity investors and other kinds of predatory capitalists have had in making money off of these assets, ripe for that kind of political behavior.
Yeah, it's sort of an unfair question to pose, one that political thinkers and others have struggled with for over a century, to answer in about 3 minutes. But to bring it all together, to bring kind of what you're talking about right now with the politics of rural America back together with the financialization of private equity. It seems clear from this discussion and from your article that rural communities affected by these closures are victims of the same kind of destructive financialization that costs urban workers their jobs, retirees their pensions, that drives gentrification in our cities and intensifies rent for tenants, that advances privatization agendas all over the place, and so on. So if nothing else, all of this illustrates that one thing that working people in rural and urban America do very much have in common. So do you think that this common ground provides a basis for beginning to break down this political divide that you were just describing, or is that too deeply rooted, too long-standing to begin to chip away at?
No, I mean, Samir, I think you're exactly right. And I think it's exactly the way I'm thinking about it and was thinking about it as I was looking into this over the summer and in writing the column. I think the challenge, the challenge and the opportunity, though I recognize it as a challenging opportunity, is to identify these points of a kind of class-based kind of coalition building, I would say, between urban and rural America. And I think, thinking about the destructive influence of financialization as having, right, as contributing to the gentrification, right, and of our urban centers and the sort of undermine, the kind of mass evictions and making uninhabitable the urban core for working people of color, and the sort of, financialization of the rural healthcare market is a perfect example of where, a common enemy and a common sort of class experience can and should be, I would want to believe, grist for, the kind of multi-regional, multiracial, working class political coalition building that I think it is going to be absolutely necessary to envision and realize if we're going to break out of the sort of political stalemate of the current moment, right? Of what the last few election cycles seem more than anything else to demonstrate, that we're sort of stuck, unable to grow, to build a progressive movement beyond a certain horizon, and that horizon, there's many ways of tackling that problem, and a lot of progressive thinkers are targeting different strategies, but the rural working class can I think should be one of those ways of imagining how to grow and break out of this political stalemate and sort of inability of a kind of progressive majority to secure political power. And I think we've talked a little bit less about it, and maybe we can talk about it in the Q&A if there are questions about it. But the pandemic, I think, in the very immediate sense, right, can be a way of suturing these communities, these constituencies, these ideas together. Since the WHO declared a global pandemic, in March or whatever, in that time, there have been, I think, 12 hospital closures since then in across the country. 9 of them have been rural hospital closures. 4 of the 12 have been hospitals that have had, that one way or another came out of the community health system sort of monstrosity, and so have been sort of laid waste by, this sort of private equity leveraged buyout, sort of predatory investment model. And again, these are hospitals like, in Bluefield, West Virginia, right? Or in sort of the Bluefield Regional Medical Center, whatever, I'm blanking on the name right now, is the only hospital, or only acute care hospital in all of Mingo County, West Virginia. A county that people who know their mining wars labor history will recognize. But and there's been other examples of that, right, where rural communities that are deeply impoverished and have been, are in this moment suffering the consequences of, at least the economic side of the pandemic double crisis, right? And if not the public health side also, are seeing hospitals close down. And it should be part of the conversation, I think, as we talk about the sort of racial disparities and other ways in which the pandemic has fallen particularly hard on certain kinds of communities. And those have absolutely been working class communities of color. They have also been financially distressed, economically distressed rural communities, both and populations that have both been of color and white, and I think ways of imagining this moment as a place to have both of those conversations at the same time, right? And talk about COVID capitalism, so to speak, as a opportunity for building those bridges. I think is, the moment is ripe for that. I think as we figure out the post-pandemic world to come.
Well, I think that is a great kind of way to wrap up and bring together various strands of our discussion and to segue into what look like some really excellent questions from the audience. So first, we have from Riley Brand, a really interesting question that I was thinking about while we were talking. How do we prevent corporate buyouts in the hospital sector to begin with, and stop companies like HCA from the egregious price gouging that they commit?
Well, so I mean, I think a more robust regulatory climate, and sort of particularly around antitrust, regulation would be the first place to start. The private equity model of leverage buyouts, followed by subsequent sort of merger, other acquisitions and mergers, and sort of buying to build and building bigger and bigger healthcare systems as a way, again, of building economies of scale. As we've heard a kind of growing conversation, particularly around, anti-monopoly sentiment in big tech, bigness, has not really been a problem for the sort of, federal regulation of sort of corporate growth and in recent years. And that's not something that's limited only to the last 4 years under, the Department of Justice of Donald Trump. That was true about Barack Obama's Department of Justice and previous Department of Justices as well. So I think, one answer is paying more, is a federal regulatory sort of oversight that would pay more attention to the ways in which individual acquisitions are often part of broader plans by private equity investors to, again, build up these very large national networks with a lot of debt, making those individual properties, sort of part of national chains, which, in some ways can eliminate sort of, what economists call inefficiencies, right? And make those entities more profitable. On the other hand, don't necessarily accomplish that, and do inevitably come with this sort of debt overhang that can sink a company or sink a hospital in the long run. So that's one answer. Otherwise, I think probably trying to build the kinds of community movements that, Samir, you were talking about and participated in Philadelphia, and, maybe using that as a way, a model for how to, build a sort of working class coalition and bring fights to rural communities that are, vulnerable to that kind of financial predation, start those conversations, I guess. So I guess, that's the short answer, but I guess it's a bit of a throwaway. Either the state will do it for us, or it's incumbent upon us, the masses, to do something. I think that's
Well, isn't that often the answer that we have to provide? I guess, well, there's several great questions here, and I don't think we're gonna have time to get through all of them. But this one from Martha Freeman, I think is an important one and relates to something that I had intended to ask you and I think skipped. She wrote, what do you know about the on-the-ground health consequences in rural areas of these financial goings on? And I guess I would just add to Martha's question that Max over the summer had a piece in Dissent called the Rural Disease Map, or in which he described what he called the Rural Disease Map. So perhaps you could talk a bit about just the public health scene in rural America, and in particular, how these closures have impacted the places that have,
Yeah, well, it's a great question, and I'll be honest. I don't know that I can. I don't know that the data is out there, and the public health experts who I'm leaning on for a lot of this work, in addition to the private equity experts, would know better than I. The sort of, if it's possible to produce data on health outcomes already in these kinds of communities. What is true, I think you can see, is that there is a real correlation between the kinds of hospitals that have been most regularly targeted for private equity investment, which again are hospitals in more rural areas and lower income areas, and particularly in the South and the Plains. Those are the areas which have also seen the greatest rate of hospital closures over the last sort of 15 or 20 years, over a similar chronology. So now that doesn't directly translate, of course, into health outcomes, but it does mean that these are the communities that private equity has been most likely to move into for its investments are also the communities that have lost acute care at the greatest rate, right? Their access to acute care over the last 20 years. In general, the health picture in rural America is worse than it is in urban America, right? I mean, health outcomes and disparities are worse in rural communities, and were well before, in terms of rates of diabetes, heart disease, pre-existing conditions, again, access to medical insurance, rates of medical debt, however you want to sort of crunch those numbers, the rural-urban divide skews against rural America. Now, the unfolding of the pandemic, as I think we've all seen, right, moved in a series of waves that really hit urban communities hardest first, and has only over the summer and fall begun its uptick in rural America. I'm not sure, maybe this is what the question was getting at, and I wish I knew an answer, and I'm sure people are doing research on this now. If you can, put the third point of the triangle in there, that, communities that have been targeted for private equity investment, which tend to be these kinds of lower income rural communities, have also, those same communities, right, which have also seen hospital closures, have also had higher rates of COVID transmission or mortality. I'm not sure. It's certainly true, right, as we are all watching, that, the South, the Plains, the Midwest are seeing some of the highest rates of increase right now in transmissions and of course hospitalizations, right? And in many cases there are no hospitals left.
Right. So I think we may have time for one more. I want to, so, all right. Yeah, we've got time for one or two more. Here's one from Devin Wiggs. How might limited partners or investors in private equity funds, like pension funds, for instance, who are some of the larger investors in private equity, like CalPERS, engage in shareholder or other kinds of activism to make private equity firms behave more responsibly towards labor?
So labor generally, in this case, yeah. I mean, it's a great question, and I think there are people, groups, organizations, and I'm sure I would take for granted, given our audience, people on the call who are deeply invested in this kind of work right now, trying to figure out how to organize power to combat private equity's growing role in the economy, and particularly the way that impacts workers. And there have been unions doing work in and around, private equity investments in healthcare. You know, I mean, I don't feel like I know the answer in a great way to this question. I think it's an essential one to figure out, and maybe there really are ways that limited partners, so funds that or institutional investors that have money invested in the funds that private equity firms are investing in these healthcare companies, can use to determine, to push back against, something, KKR, one of the more prominent private equity firms, drew some flack, rightly, early in the pandemic for it owns a bunch of physician staffing firms and large physician staffing firm chains. And in the height of the pandemic, back in the spring, started freezing salaries or laying off and furloughing workers, physicians, right, as a way of trying to stem losses, right, that all healthcare companies and practices providers were confronting in the spring and summer as elective procedures were canceled and all of that. What the institutional investors whose money was managed by KKR and invested in those physician staffing firms might have done behind the scenes, I don't know, but I know that there are, labor organizers thinking about how to crack the private equity nut right now, and I'm sure they're trying to think of it, and they should, and that should be part of the conversation, I guess. Also, probably in terms of the earlier question about, greater regulatory oversight around antitrust questions and sort of, kind of brick and mortar, or, on the bricks, on the streets, sort of mass organizing is also some of that sort of strategic corporate organizing and organizing around investments that unions might be able to do. So
great. And so I think we can do one more. And I'm, to those who submitted questions and didn't get them asked, I apologize. There's so many. It's hard. I wish we had 3 hours to go through this, but they're just terrific questions. So let's close with one that I think is a nice way to kind of conclude this discussion, from Abdul, who notes that, he says, considering that the urban-rural divide has been an endemic problem in most countries, which I think is a really important thing to note. It's not unique to the United States, of course, right? This is in most places this is a political challenge. Are there any global movements now or historically that have tried to connect rural folks? And I guess perhaps just, is there a way of thinking about this problem as a global problem rather than one particular to a nation state? And he notes that, for example, the way that Prime Minister Modi in India has an agricultural liberalization program that is proving to be devastating to farmers, and is very much in the interests of big agribusiness and other multinational corporations. So is there a way to imagine this internationally as well?
Yeah, I mean, I think absolutely, in the sense that I think, right, this urban-rural divide that exists sort of within all sort of national contexts and most broadly, from a kind of world systems perspective, sort of globally, should be an opportunity for connecting a lot of different kinds of movements that are working around, agricultural liberalization, healthcare privatization, right? Other kinds of sort of global movement of real estate capital and things like that can be entry points, I guess, for building a kind of, not just interregional national coalitions, but international global coalitions of working people and consumers, who are in different ways, victimized by these kinds of, global financial entities, right? I mean, private equity is not in any way a national concern. It is, absolutely a global. I mean, these firms and these investors have global ambitions and global perspectives as they assemble their portfolios. And I think it would be, if we're thinking seriously about how to push back against their power in any individual sector of the economy or even sub-segment like rural healthcare provision, right? It would be unwise to ever lose that sort of global international picture on the one hand, because it reminds us of just how powerful these financial entities are. And on the other hand, as I think Abdul, your question is speaking to in a really good way, points out other opportunities for coalition building, right? In the way that labor and other groups have figured out all sorts of really creative ways of, doing coordinated actions with unions across Europe and other parts of the world to take on, multinational employers that they're in contract struggles with or otherwise. I think, we should think globally and keep in mind this rural urban divide as, a sort of a real division out of which capital is able to time and time again seek out ways of increasing its value proposition, right, and make money off of that division. And so we should figure out ways to push back against it.
Great. Well, I think that's a really nice way to wrap this up. Max, thank you so much for joining us. I really enjoyed this discussion.
Me too. Yeah.
And thanks to the audience for being here for another COVID capitalism series. I hope everyone's having a safe we'll have a safe holiday, and will join us for, we got several more of these scheduled for the rest of the year. So thanks again, Max. Thanks everyone. And we'll see you next time.
Thanks, Amir.